Hi everyone, this is Gina Herrera again, giving you the lecture titled Labor Part 1. This is part of the intrapartum concept lectures. Okay, some lecture objectives are to discuss the normal labor process and the process of giving birth. It's to understand the nursing interventions for normal labor, to review specific high-risk complications and nursing responsibilities of the antepartum as well as the intrapartum period. So this is the fun stuff. I like the assessment stuff, the prenatal testing and the prenatal assessment, but I'm a labor and delivery nurse and my heart is totally into this labor stuff. So I absolutely, I'm in my element, I guess you could say. All right, so moving along. The factors that are important to labor and birth: the birth passage, so the passageway that the baby would come, okay, the fetus itself, the relationship between the passage and the fetus, the physiological forces of labor, as well as the psychosocial considerations. So I guess before you can even go into, all of this, you have to know what is labor. And labor is a process by which the fetus is expelled from the uterus by systematic contractions. And remember I said that uterus is a big muscle. So the muscle will tighten and it will relax with those contractions, and those contractions will open or dilate the cervix and efface, thin out that cervix, which pushes the baby through the birth canal to be born. Another name for labor is parturition. So there are some signs of labor, and these are the signs that make us think, maybe I'm going to go into labor real soon. Different changes begin to occur. So premonitory signs: increased Braxton Hicks contractions. Remember those annoying tightening and relaxation contractions that the uterus usually will have earlier in the pregnancy, and I said they were kind of like practice contractions. Well, these get more increased in number. You'll also get lightening. And lightening, remember we talked about the fundal height when the baby drops down those last few weeks. So the baby's dropping down, getting closer and closer to the birth canal to kind of line up and prepare for labor. So this is when that mom says, I've dropped. Well, that's what it is. The baby has dropped down. So it's called lightening. It's the term for it. Rupture of membranes. Remember, the water bag is the membranes. So when the water bag breaks, we say the membranes are ruptured. They've broken. And then they get that gush of fluid. Bloody show. Whenever the cervix dilates, or any tissue for that matter that has any change or there's trauma to it, they will have some bleeding. Well, bloody show, if a patient has bloody show, that's telling me that she's got some cervical changes going on. Her cervix is either softening, it's dilating, there's definitely some change. It's a mucousy bloody discharge, not so much just thin blood, watery blood. It's more mucousy. And when a patient, has that, we know that they're in labor and they're dilating. It's called bloody show. An increase in energy level. Well, the mama duck is getting the nest ready for that baby. So they get this burst of energy. They might have been dragging tired at the end, okay? But all of a sudden they wake up and they get this burst of energy. I got to get everything in line. If I have other children, I got to figure out who's going to take them where, when they need to be where. I got to get my nursery together. I got to make sure my bags are packed. I got, everything in order. So they get that burst of energy, I guess, just to nature's way of helping them get this really going on because we're going to have a baby. So I guess it's just excitement as well, and energy, that nervous energy maybe, but they get a burst of energy. Okay, cervical changes. Well, Cervical changes include that softening of that cervix. You know, when I talk about cervixes and with my students, I'll say if the cervix is green, it's not ready. So just like a piece of fruit, if it's green, it's not ripe, it's not ready. The doctor may go in and do a thorough exam at the end. If they're thinking about possibly this patient going into labor or doing something, they might look at that cervix and see if it is softened, or they can examine it and feel it if it's softening, if it's dilating or opening, or if it looks like it's thinning out. There's some cervical changes that would tell us whether that patient is ready or not to deliver. Distinguishing true labor from false labor. So true labor contractions are the ones that are going to change the cervix, or going to change the consistency, make it open. The false labor are just contractions that occur almost kind of like the Braxton Hicks. They're not really doing anything to change the cervix. They're just more happening. These are the ones the patient is just too excited and too happy, and we know that these are not real contractions, because the ones that are real, they usually take your breath away, and they become more and more regular, and they are the ones, like I said, that do the work with the cervix. Those are the ones that change that cervix. So here we are. True labor. Contractions become progressively closer together. They dilate and efface that cervix. So those are the ones, again, that change the cervix. False labor or prodromal labor. Contractions do not result in observable dilation and effacement of the cervix. And there is a table 7-1 on page 196 in your text that talk about distinguishing true labor from false labor and how we can tell those apart. So maternal response to labor. So mom's body changes in response to labor. Okay, cardiovascular wise, there's an increase in blood pressure with contractions. Of course there is. It's painful. It hurts. So her blood pressure may go up with those contractions when she's having a contraction. Also, the maternal position can affect the cardiac output. Remember that supine hypotensive syndrome or that vena cava syndrome, that can interfere with the perfusion. We said that baby can get hypoxic if that big old uterus is sitting on that vena cava and causing mom's blood pressure to drop. So that's something we need to consider. Respiratory, there's oxygen demands and consumptions that will increase as mom's in labor. She will have an increase in the depth and rate of respirations. That's what we tell them, slow, deep breaths with contractions. You don't want to hyperventilate. And, again, that wouldn't help with their oxygen demand and the perfusion to the baby. So different changes going on there. Gastrointestinal, everything slows down. Remember that? Everything slows down. Decreased motility. Gastric emptying time is prolonged and gastric volume remains increased regardless of when the patient had her last meal. I will tell you, I was in labor and delivery, and it was one Sunday. One of my patients came in, and she's like, I knew I was in labor, but I have to tell you, nurse, I had to have my Sunday meal at Ruth's Chris. I had to have that cream spinach and my steak. I was promised that we were going to go out to dinner, and I just so happened to be in labor, but I really did want that, and I was craving it. So, I told my husband, anything that goes on after dinner, we'll deal with it later. Well, let me tell you, I saw her whole Ruth's Chris menu come on out. When she went into true labor, of course, she was in labor, she, of course, couldn't hold her food down. It comes back up. Again, it just sits there, and that gastric emptying time is prolonged, so it doesn't go anywhere. So they will, they will repeat it later and give it to you to clean up. But anyway, but yeah, she didn't keep it down, and it came right back up. But she was so happy because she got her meal, and that was her, that was her goal for the day. And then the rest of the day, her goal was to have the baby. So, but GI, decreased motility. Remember, we talked about how it's so slow. Everything slows down. All right, the urinary system. Reduced sensation of a full bladder. They may have edema from the pressure of the presenting part on the bladder. So they have this pressure, but it's a reduced sensation, because again, there's a lot of pain going on there, and you may not feel that full bladder. Also, if you're getting some kind of pain relief that's going to numb you from your waist down, like a good old epidural, you may not feel that bladder filling up to empty it. So, that's when we use a Foley catheter. We'll put a Foley in if they have some kind of epidural or anesthesia. Hematological, the white blood cell count will slightly increase, which is a physiological response to stress on the body from labor. Labor is very rough on the body. It's very stressful. It's painful. And the body, of course, reacts. It's, again, ready to fight. WBC count goes up a little bit because they know that this is not normally how the body would function, that there's some kind of stimulation going on here that's going to cause that, cause mom to have that pain, and things are changing. So in defense, the white blood cell count will slightly increase. There's also an increased risk for venous thrombosis during pregnancy and postpartum period. We talked about that. We want our moms to change positions, not to sit for a very long amount of time. If they're traveling, get them out the car every so often to walk around. Actually, the best way to travel is by train, believe it or not, because they can walk up and down the train cars and not necessarily have to stay in their seat the whole time. But anyway, so hematological change as well. How does the fetus respond to labor? Hemodynamic changes can occur, placental circulation. So there's a decrease in maternal fetal transfer of oxygen and nutrients during a contraction. So remember that uterus is a big muscle, and when it contracts, there's temporary cessation of perfused oxygenated blood going to that muscle. Usually with a healthy fetus, they can withstand the anoxic periods during the contraction, and they have enough oxygen reserves to get them through. But it's when we have not a healthy fetus that they begin to have some issues. Cardiovascular-wise, heart rate is rapid and changes based on fetal response to stress of contraction. So, again, 110 to 160 is the normal range for the fetal heart rate. And depending on what's going on, I can remember examining a patient. Her baby was down enough that I could tickle that baby's scalp. And when I did a little tickle job on their scalp, their heart rate jumped right up and went way up, got excited. So, they can feel things. And again, they can feel contractions. Sometimes the contractions can cause them distress, and their heart rate can drop depending on what's going on with them, with their, oxygen levels. Or they can take off and accelerate, if they get excited. So the cardiovascular system has some changes. Pulmonary system, increased absorption of lung fluid. They do get some fluid in the lungs, and usually as they're coming out, that all that squeeze through the vagina, if they're a vaginal birth, they usually get that all kind of just gets pushed out of the lungs, and you'll see a lot of fluid come out the baby's mouth and nose. That's why we suction the mouth and nose to get any additional fluid that's, that they get in their lungs from the birth canal. But if they don't have that suction, remember, if they're C-section, if they don't get that squeeze out like they would with a vaginal birth, then that's those babies that we always expect them to have those wet lungs, those C-section babies. They got beautiful heads, but they got wet lungs because they don't get that squeeze. So it's not uncommon for us to auscultate the lungs of our newborn that was a C-section baby and them have some little, congestion or crackles. That's kind of normal because they didn't get all that sucked out. So fetal sensation, beginning at 37, 38 weeks, the fetus is able to experience sensations of light, sound, and touch. They can hear their mama's voice, and they can also feel the practitioner doing vaginal exams during labor. And like I said, sometimes they get excited, their heart rate goes up, and, they can respond to fetal, to the touch, and they can hear, and they can, again, They're aware of what's going on. You want to refer to table 7-3 on page 202, the various fetal physiological responses to labor, and you want to read over that chart. So we say the 4 P's of labor and delivery: the powers, the passage, the passenger, and the psyche, and we're going to go over each one of these. So the powers, this is the physiological forces of labor and birth that include the uterine contractions and the maternal pushing efforts. So it's not just the forces of the labor contraction, but it's mom's actual ability to push. The uterine contractions are rhythmic tightening of the uterine muscle, which results in expulsion of the fetus. The uterine contractions are responsible for the cervical effacement and dilation and are coordinated, involuntary, and intermittent. Okay, so that is what's going to make the cervix change, those uterine contractions. Maternal pushing efforts, after and only after the patient is fully dilated, this can occur. The pressure of the presenting part on the pelvic floor causes voluntary and involuntary bearing down or pushing by the mother. So if you get a mom that does not have any anesthesia on board and you tell her, don't push, we got to wait for the doctor, good luck with that, because she's going to feel the urge to push. And the best description I can tell you is that they feel like they're getting ready to have a bowel movement and they can't hold back. So again, all of this is considered the powers. The passage, this is her pelvis. That's the passageway, the pelvis. So there's, the bony pelvis, it consists of a bony pelvis, soft tissues, and then we talk about clinical pelvimetry. But if you look at the pelvises, there's different types, the gynecoid, the anthropoid, the andropoid, and the platypoid. If you look at the gynecoid, that is the most favorable pelvis for delivery. You can see it's almost like the shape of the baby's head, okay? Platypoid, it's kind of like an oval shape, and it's not real conducible to having the baby come down and pass through there. The android is a heart shape. It's definitely a different shape, and it's not as conducible as the gynecoid. And then the anthropoid, it's also elongated, but it's not so much horizontal. It's up and down. So anthropoid is definitely not conducible to that baby's head most of the time. It doesn't fit as well as the gynecoid. But gynecoid is what mainly women's pelvises are shaped as, but not to say that different cultures have different bone shapes and they can take on other shapes. The clinical pelvimetry is measuring the dimensions of the pelvis to estimate the pelvic size and adequacy for birth. So if you have a really good OB doctor, they're going to check your pelvis based on the size that they feel your baby is to make sure that your pelvis can accommodate that baby. And if it can't, and it's not going to happen, then, sometimes they'll say, this baby's just too big. We're going to have to do a C-section. Or, you know what? You're 39 weeks. I think if we wait another week, we're going to have a problem. So, they may induce them. Remember, they can induce 39 weeks without a medical reason. But before that, they have to have a medical reason. So, I guess it just depends. So we say our diabetic babies are really big babies because they get all that sugar, right? So that right there, before that baby gets too big and mom has to have a C-section, they will induce them 37 weeks, 38 weeks, because that diabetic baby is so big and they want to give them an opportunity to deliver vaginally. So that right there, diabetes is definitely a medical reason for the size of the baby too. So, all right. The passenger is the fetus. So the fetus takes on different positions. When we say position, we can refer to the lie. How is the baby lying? Is it vertical? Is it transverse? The attitude, the flexion and extension of the body in relation to the fetal parts to one another. Okay, so that's like, you know, baby's got its arms out, baby's got its arms pulled in. Presentation, is it cephalic? Is it shoulder? Is it breech? The gestational age, how big is this baby? Again, you know, depending on how the gestational age is this a big baby? Did we wait to 40 weeks? Or is the baby overdue? Bigger, you know, babies usually can gain most of their weight at the very end. The muscle tone, and then of course the size. So a baby greater than 4,000 grams is macrosomic, or has macrosomia. And that is a very big baby. And a lot of times that will describe our diabetic babies. They're just big babies, you know. And don't let that fool you. The big baby is great, but that doesn't mean the lungs are formed, you know, because you can have a 8-pound baby, 36 weeks gestation, that might be 10 and a half, 11 pounds at birth because its mom is diabetic and they got all that sugar going, but those lungs may not be where they need to be. So it's not always just the size. We have to look at a lot of things. Okay. When we talk about, again, that passenger going down, you know, the relationship with the fetus and the passage, we talk about engagement or descent as the baby descends down, movement of the fetal presenting part into the true pelvis. That's where we, you know, getting ready to deliver. The station refers to the relationship of the presenting part to an imaginary line drawn between the ischial spine. So mom's ischial spine, she has the spine on each side of her pelvis, and there's an imaginary line. If the presenting part is above that imaginary line or those ischial spines, it's in a negative plane. If it's below the ischial spines, it's considered to be in a positive plane. So we're going to need to know that. So if, you know, when we determine, you know, the station that of the presenting part, we have to determine, is it in a negative? If it's at the ischial spines, right at the ischial spines, it's at a 0. It's a 0, okay? Fetal position refers to the relationship between a designated landmark on the presenting fetal part and the front, sides, and back of the maternal pelvis. So when we look to say, is the baby head down? If it's vertex, the occiput is down, okay? If the baby's got its head cocked back and it's looking out, it's a face presentation. We call that a mentum. And I can tell you, pretty much 90-something% of the time, if it's a mentum presentation, the baby's going to be a C-section because that just can't fit through, okay, the way the baby's got its head. If it's breech, we call that a sacral or a sacrum presentation. Shoulder presentation, where the baby's shoulder first. Acromion process. Acromion process. When we talk about breech presentation, there are different breech presentations. So if you look at the first letter A, that's a baby's kind of jackknifing out. That's a frank breech, okay? The difference between the frank and the complete of full breech is that the baby's legs are extended with the frank breech, and they're in that jackknife position where the baby's kind of got its legs closed and it's folded with complete. The footling, there's 2 different types. C is that footling or single footling delivery presentation. And then if the baby's got 2 feet out, it's called a double footling breech. So there's different types of breech presentations. And just so you'll know, they C-section patients for a lot more sillier reasons. If the baby is breech, you don't want to take any chances. They usually C-section because of the presentation being in the breech presentation. So we have had twins that they were head down. And when the baby came out, the first twin, of course, it was delivered vaginally. The second one had all that room. It decided to take a flip job and went into a breech position. So poor mom had to have a C-section as well as a vaginal delivery. But sometimes that happens. They get more room inside, so they decide to move around and flip themselves upside down. So, but most of the time, breech presentations, I can tell you 99% of the time, they're going to C-section. There are mechanisms of labor, and we call these cardinal movements. this is definitely something you want to know, okay? Descent and engagement is the movement of the fetal presenting part into the true pelvis. So again, when the baby's engaged, we know that that presenting part is in that true pelvis. Then the flexion will occur. This is where the fetus will assume a chin to chest position to aid in descent. What easier way to put the chin to the chest to help that head take form to pass through easy. And then internal rotation, the fetus will turn to place its largest diameter of the head in line with the largest diameter of the pelvis. So they're trying to squeeze their way through, and they're trying to figure out what's the best way to move my head to get through, okay? Then you have extension, rotation of the head below the symphysis pubis, restitution, where the fetal shoulders will enter into the maternal pelvis in an oblique position. External rotation, the shoulders rotate into the largest diameter of the maternal pelvis and the fetal trunk moves through the pelvis. And then expulsion, the fetus is fully expelled from the body. So yes, these are mechanisms of labor, cardinal movements, and are very important for you to know. All right, passenger continued. It's not just the baby, but it's the membranes. Remember we said the membranes, the water bag breaks, and the membranes are full of amniotic fluid, and we call it the rupture of membranes when they break. Well, the membranes, the amnion and the chorion are the layers of the membranes, and then of course the placenta, where it's implanted on the wall of the uterus. Well, that placenta comes out after the baby, and it's part of the passenger. It passes through the birth canal as well. The psyche. All right, that is my fourth P. And that's maternal readiness for labor. Is she ready? Does she have any fear, or is there any tension? Because she knows she's going to have some pain, okay? Did she have any past traumatic issues with previous deliveries? If they've had a horrible delivery and they ripped and it was just not a good thing, they could have that whole, again, it's almost like a PTSD, but with, delivering a baby. They're freaked out. They're afraid of what is to come, so that could cause some issues. Educationally prepared. So now there's so many things out there. I mean, when I was pregnant, we just had the books, now we got websites, we got, more classes being offered to educationally prepare mom for what's to happen, what kind of things are going to happen to her body. And, that's always really good. That helps to ease a lot of the tension and the fears if they're educated and they know what to expect. So cultural practices, we got to respect the cultural practices. I mean, we do have some cultures that do not want men in the room. They do. I mean, my male students, I'm like, oh, I'm sorry, I can't let you in that delivery. Because the culture, they definitely, have certain cultural beliefs that we need to respect. So cultural practices definitely play a part. Social support, who's with the patient? Who's the patient's biggest cheerleader? Most of the time, it's the significant other, or the partner, or somebody, or it could be auntie, or it could be their grandmother, it could be, anybody. But a lot of times, sometimes, it might just be the nurse if nobody's with the patient. And, you're the support person, and you're the one that's going to be in there. I can't tell you how many times, even though they had support people, I would be in on, a labor patient all day. I'll come in at 6:30, take care of her, and my shift ends at 7:30, and they would be like, oh, I'm so close. Can you just stay with me, please? I felt like I was just, doing really well with you taking care of me. And I can't tell you how many times I have stayed over my shift just to take care of my patients and be there for them. So social support, it might be the nurse. When they get admitted to labor and delivery, there's a lot of things that go on. We want to greet the patient, establish a rapport with them. We asking them, when's the last time you ate or drank? Have you emptied your bladder? Did you have any plans for pain relief if they're truly in labor and they're admitted. You want to get their vital signs, get their admission assessment done, contraction monitoring, frequency and intensity, fetal heart rate monitoring. So if you don't know anything else after this slide about what I'm going to tell you, you've got to remember this. The fetal heart rate, unless the baby is coming out the vagina, the fetal heart rate is your priority. So as soon as you get that patient in the room, they will put on a gown, you put them in the bed, and instead of hooking up that blood pressure monitor and taking vital signs and letting them just sit in the bed, you want to put them on that fetal monitor. We want to see if our baby's okay. So that is your priority. Okay, like I said, unless they're close to delivery when they're walking in and the baby's hanging out, you can get the baby's pulse when it comes out, actually. So, but as long as that baby is in utero and nothing's happening anytime soon, you want to make sure, because I can't tell you how many times I've put patients on monitors and I've seen some really disturbing strips, and sometimes that changes the whole game plan of what's going to happen with our patients. So fetal heart rate monitoring, you want to get that baby on that monitor so we can see if that baby's doing okay. Urine and blood samples, okay. Intravenous fluids might be started if ordered to prevent dehydration. A lot of our patients are NPO. Sometimes they're NPO except for ice, or if they're Lamaze, they may get popsicles or Gatorade or whatever. Sometimes they have other things going on, and usually our Lamaze patients, they may or may not have an IV. I mean, they may not want an IV. So, it just depends on the status and the request of the patient, and if the doctor's on board with all of it. So the patient may be allowed, again, ice chips, popsicles, sips of oral fluid, depending on what's going on. Comfort measures and pain relief options will be discussed if desired, and documentation of the admission. So all of these things are kind of what goes on when the patients get admitted, and they're going to stay with us. All right, this has only changed a million times when I've gone through this lecture. So this particular book, we're going back to what it used to be. So in the other book, it was completely different, but we have labor stages. There's a first, second, third, and fourth stage of labor. But the first stage is the trickiest because there's 3 phases, okay? There are 3 phases, a latent, an active, and a transition phase. So with the first stage of labor, this is the latent stage, is the start of the contractions. This is where mom goes from 0 centimeters to 3 centimeters. This can last 10 to 14 hours, okay? Know that patients that have had deliveries before, sometimes things are a little bit quicker to happen than if it's their first baby. Usually first babies, mom's in labor for the first time, this could take a long time. It may take longer, okay? Contractions here are mild and occur every 5 minutes. Patient here is very excited about the labor, and she's very chatty and sociable. She's, this is fun, okay? Oh man, if it's like this is a walk in the park, but not really, because it doesn't always stay that way. So that's latent, okay? And you can have patients, I was 3 centimeters walking around in the street with my first baby. So, I don't know. I was, I guess, in latent labor, but I wasn't having any contractions. My cervix was definitely changed. Active is that second phase. That's when they're 4 centimeters to 7 centimeters. This is called the acceleration phase. With this phase, you can see dilation of 1 centimeter an hour for the nullipara. A nullipara is somebody who's never delivered a baby, okay? So 1 centimeter an hour is how they're going to progress. 1.5 or 1.5 centimeters an hour for a multipara, somebody who's given birth before. Their body has gone through this, and they pick up where they left off. So again, you can see that the multipara, things change a lot more every hour than the nullipara, somebody who's never delivered a baby before. The contractions are moderate to strong in intensity and occur more frequently, so every 3 to 5 minutes. Yeah, this is not fun anymore. It's not fun. It's starting to get crazy. Okay, so patients are very focused on the contractions and is more focused on the demands of labor. You know, this isn't what it was before. We're not so chatty and happy. Cervical dilation advances more quickly with contractions being more intense and stronger. Okay, so yeah, it's gonna get really nasty, you know. And then that third phase, transition. That's when the patient goes from 8 centimeters to 10 centimeters, and we call this the deceleration phase. Fortunately, this phase does not last long. It's very similar to or even faster than the active phase. Usually, again, nullipara is 1 centimeter an hour, 1.5 centimeters an hour for the multipara. And the contractions occur every 2 to 5 minutes. So as you can see, they're getting closer together. They're getting more intense. It's considered the most intense phase. Here, the patient may feel that she can no longer continue with the labor and can be very irritable, okay? Patients may also feel rectal pressure and the urge to push. There's an increase in bloody show because a lot of changes going on, and the rupture of membranes will occur if they have not already. Not necessarily. I mean, sometimes we still have to break that water. That water bag is pretty tough on some of our patients, and it just doesn't break. So they may have to go in and artificially do it. But a lot of time, you know, sometimes they will break their water in this phase. They are not happy here. Let me just tell you. They've lost their mind. They're cursing you out. They're grabbing you. They're squeezing your neck. They pull you into the bed with them. You know, I had one significant other said, I think my wife has lost her mind and she's totally out of control. And I'm like, yes, but it's temporary. She's just in transition right now. And, you know, she's at a point in her labor where, you know, this is kind of tough. But it's going to be okay as soon as she delivers, I promise. And sure enough, you know, she was like, oh, I'm so sorry. I didn't mean to insult anybody. I hope I didn't offend anybody. But, you know, we do expect this because transition is definitely one of those trying phases for labor. All right, so stage 1 is from being closed to going to all the way 10 centimeters, okay? The second stage of labor is from, okay, this is full dilation through the actual delivery of the baby. Okay, so they go from fully dilated to the delivery of the baby. That's the whole second stage. This lasts 30 minutes to 3 hours for a nullipara. Again, this is somebody who's never delivered before. 5 minutes to 30 minutes for a multipara. Okay. All right, the third stage can last up to 30 minutes, and it's considered normal. And this is the delivery of the baby through the delivery of the placenta. We never yank or pull that placenta out. If the baby comes out and the placenta is still in there, the body has to contract that placenta out. And it contracts, and the placenta should spontaneously slip out, okay? You might see the doctor tugging on it just to kind of tease it, to see if it'll push it out, okay? But you should never see anybody yank it out, you know, because you can pull that placenta out and fragments of the placenta can be retained on the uterine wall, and that patient can have a severe hemorrhage issue because that uterus cannot contract after to stop the bleeding if there's fragments of the placenta stuck in the wall. So definitely, you know, again, up to 30 minutes is considered normal. Sometimes we just sit there and wait for that placenta to come out. And that's, you know, again, the delivery of the baby through the delivery of the placenta is stage 3. Fourth stage of labor lasts 1 to 4 hours. So it's from the delivery of the placenta through the first 4 hours of postpartum, okay? So that patient may go to the floor, to their room, and still be in stage 4. So 4 stages of labor. The only one that has the phases is that first stage. And you want to know this for sure, okay? You're going to definitely have to see this again. All right. So here's some pictures of stages of labor. Stage 1, stage 2, stage 3, and of course, you know, stage 4. You know what that is, you know, from the delivery of the placenta to the first 4 hours. which is very, it's a really critical time. You know, they can hemorrhage and all that. We do in our recovery. And by the way, with recovery, they recover usually 2 hours in labor and delivery. So the first hour we're doing vital signs every 15 minutes. And then we're doing the second hour vital signs every 30 minutes. So you should have at least 6 sets of vital signs in recovery or more if something's not right. You know, if they spike a temp or, you know, something's wrong, you might have to do it more often. But, you know, protocol is every 15 minutes the first hour, every 30 minutes the second hour. Now, if you get a patient that has a tear or a laceration, you know, or even an episiotomy is made, sometimes they'll put ice to the perineum. And usually they put it on for 20 minutes at a time and remove it. And then, you know, they'll put a fresh, and when I tell you ice, I don't mean just a little ice pack. Usually we fill a bag with some ice from the ice machine. We don't fill a bag, I'm saying we fill a glove, you know, a rubber glove, and we tie it in a knot and we put that right on top mom's perineum. What better way to prevent the swelling from getting out of hand is, you know, just to put that ice right away. And you want to make sure every 20 minutes because it can melt with mom's body heat. So we want to make sure that she gets enough ice to her perineum for the swelling. So on that note, I have a question. The 4th-stage nursing care for a client with an episiotomy includes which of the following by the nurse? Select all that apply. Application of ice beginning 4 hours after delivery. Ice pack to the perineum for up to 60 minutes per application. Inspection every 15 minutes during the first hour after birth. And instructions to avoid intercourse for at least 12 weeks. Ice packs to be applied for 20 to 30 minutes and removed for at least 20 minutes at a time. So if you picked C and E, those are the correct answers. Now, why isn't it A? Application of ice beginning 4 hours after delivery. At that point, it's way past the time. She's already swollen, okay? So we want to do it immediately. Ice pack to the perineum for up to 60 minutes per application. The ice is probably going to be melted and it won't be very effective. So you definitely don't want to leave it on for a whole hour before you change it out. Inspection every 15 minutes during the first hour after birth. Yes, we're looking at her bottom. So it's not just the vital signs every 15 minutes, but we're also looking at her bottom, making sure it's still intact and there's no dehiscence of stitches or, you know, sutures coming apart. We want to make sure she's not hemorrhaging, that her uterus is clamping down. So those checks is just not inspecting her bottom and vital signs. We also need to feel her abdomen. Make sure that uterus is rock hard, it's balling up, because in order for that bleeding and hemorrhage to stay under control, she has to have a nice, hard, you know, uterus that's, you know, again, it's contracting down to continue to keep that bleeding from coming out and that patient having no risk for hemorrhage. So C, definitely. Instructions to avoid intercourse for at least 12 weeks, that's probably the most inappropriate time to talk about that right after delivery. That's probably the last thing she's thinking about. So save that for your discharge instructions. Nothing in the vagina for 12 weeks, okay? Ice packs to be applied for 20 to 30 minutes and removed for at least 20 minutes at a time. So yes, definitely. So it's C and E would be the correct answers. All right. And that concludes this lecture. And like I said, this is one of my most favorite lectures, and I feel like I'm in my element. But if you don't feel like you're in your element, that's okay. And if you have any questions, of course, please feel free to email me. I'm willing to answer your questions. I'll meet with you if you need help with anything. But we got to make an appointment because, you know, there's so many things going on. If I have an appointment, I can definitely take that time with you. It was a pleasure giving this lecture today, and I hope you have a wonderful rest of your day. Until next time.